Now, by now, I'm almost positive that you have heard the concept of relapse. You'll hear it referred to in addiction, but you'll also hear it referred to in other negative mental health symptoms. But this really grew out of the AA model. The main forming of AA was a layman. He was not a researcher or a counselor or a psychologist. He was a layman, and he realized that it was easier for him to stay sober when he was helping someone else stay sober. And this is a great concept, and it's something that's important for all of us to note and to use that in our counseling, regardless if you're dealing with an addiction problem or not. So I'll give you an example. I grew up in California, Los Angeles area, and so anyone who lives out there, who's ever been out there, knows that one of the things that you generally don't do when you're crossing the street is you don't go up to the stoplight and go across. I'm not going to say never, but usually you just kind of zig and zag between cars and cross the street, and that's something that I did all the time, except when my children are with me. When my children are with me, I'm going to go up to the stoplight, I'm going to hit the little button, I'm going to sit and wait no matter how long it takes, and I'm going to cross the street inside the crossing lines. Look both ways, make sure no cars are coming, and make sure everything's really safe. And that's the concept of it's easier to stay sober when you're helping someone else stay sober. It's an amazing concept, and it is very true, and it is essential to helping your clients grow and improve. However, not everything inside the AA model is research-based, and relapse is one of those things. The concept of relapse and the concept of when you make a mistake or you return to using or return to symptoms that you have to start all the way back at the beginning, throw away everything that you've done at that point and restart. That is a very unhealthy model. It causes a significant amount of shame. And most importantly, when you're dealing with drugs and addiction, it fosters or really encourages or increases the likelihood of overdose and even death. And I'll just give you a little bit idea of what that concept is. If I have been sober for 3 years and I use heroin once, and that means I have to go all the way back to the beginning. I have to go to my meeting and be shamed in front of everyone. I might as well just keep going for a while. And so having to pull back out of that after that with increased shame and just that embarrassment of going back and showing everyone that I started all over again, that can be so weighty that people will just go into a binge, potentially overdose and die. I have had that experience in my personal life. We had a very good friend of ours that we worked with for a long time. He worked doing hurricane relief, just selflessly, constantly working. This was after Hurricane Katrina, and he'd come to the area because he was in an addiction treatment program. It was a dry program with no medication. He had gotten sober, and he stayed, and he just worked voluntarily to help the survivors of Hurricane Katrina, and he did this for a long time. One day he was driving by himself, and he saw someone walking, and he thought, I'm being nice and helpful, and I'll offer that person a ride. And so he did. He offered him a ride. In doing that, that man offered him heroin, and he turned it down and said no. But unfortunately, when he got out of the car, he threw the heroin back into the car. And in a moment of weakness, he relapsed, and he did use that heroin. And so that's the term, relapse. And so in his mind, he started all the way back at the beginning. And so I won't go through the whole story, but I will let you know that it did end in his suicide because of the shame of falling back and relapsing and starting all over was so heavy for him that he was not able to pull out of it. I had a similar story happen with one of my clients. This client had worked with me for about a year. He had been sober for longer than that. He had come into treatment and had a previous counselor before me. So he was about 2 years sober. He was working at the time, and one of his coworkers asked him for a ride home. And he gave that coworker a ride home. And at that time, so it was Friday night, the coworker again gave him heroin, a similar concept. And so he did. He took that heroin one day on Saturday. He took it. And he was so overcome with shame when he came in to see me on Monday. He asked me to complete his drug screen, which isn't normal, right? A counselor doesn't normally do the drug screens. But I could tell that he was very upset. So I came in and asked him, what was going on. And he just burst into tears. And he said to me, I threw it all away. I'm back at the beginning. I'm all the way back. It's all over. It's wasted. I asked him what happened and he told me. And so I said to him, tell me what you were doing the day before you came into treatment. I was working on a medication-assisted treatment facility, and so he was on methadone and had, like I said, maintained his sobriety for about 2 years. So I asked him to describe what he was doing the day before or when he decided to come into treatment. And he told me that he was laying on the street on the floor with his arm in the gutter, digging as hard as he could to try to get some needles out of the gutter. And laying on that floor, digging in to find needles in the gutter, he said to himself, I have to do something. And that was when he decided to come to treatment. And so I said to him in very plain language, I said, okay, I'm hearing you say that you're back at the beginning. So yesterday you were digging needles out of the gutter. To which he responded, no, I was not. I just used some heroin on Saturday. It's like, okay, so you used some heroin on Saturday. Tell me what you did on Sunday. And he said, well, he was miserable. He went into withdrawal and he just stayed by himself. He didn't want to tell his significant other what had happened. He was so ashamed. So he just locked himself in his room and just stayed there and was sick coming off of the heroin. Well, it was Monday now. And so I'm saying, okay, so what I'm hearing you say is that on Saturday you used heroin. On Sunday you were strong enough to not use it, to take that withdrawal all by yourself. And then on Monday, the very first thing you did was to come in and tell me what had happened. And I asked him to compare from where he was digging needles in the gutter to where he had been on Friday, how many steps forward he had taken. And he's like, I don't know, 500. I said, okay, if you took 500 steps forward, tell me how many steps backwards you took this weekend. And he said, I don't know, maybe 3. I said, okay. So you are still 497 steps away from where you started. So where do you want to go now? Are you going to keep going forward, or do you need to go backwards a little more first? And he looked at me and he said, I want to keep going forward. I said, okay, so tell me what's next. What's your next step? And he said, well, I need to tell my significant other what happened. So we sat and we talked through and we role played and talked about how he could do that. And that was his plan for the day, to talk to his significant other, which he did successfully treat. He did go back to full sobriety, did not, to date, to my knowledge, he's not relapsed or returned to use again. And so when you talk about that idea of relapse and you talk about that idea of starting back at the beginning, it's really important that we ourselves as clinicians, and you'll hear me say, I just did a second ago, I just said relapse a second ago. You'll hear me still working on changing my own words because it's just so enthralled in everything that we do. But we really want to change that to the more scientifically accurate term, and that would be return to use. And again, it's the same if you're talking about anxiety, depression, dependency, sexual addiction, pornography, any type of negative behavior. When the client takes one step backwards, they should not be treated as if, and they should not be viewing themselves as if they went all the way back to the beginning. And so help your clients develop a return to use or a return to symptom plan where you go ahead of time and say, how will you handle it if you return to use? What plan do you have in place? I did have a return to use plan with the client that I just described. And guess what the first step on his return to use plan was? That was to tell me. And he did. He followed through on it. The very first thing he did when he came in on Monday was he told me, and then we were able to work together, and I was able to strengthen and encourage him and help him to move forward and not keep going backwards. And so it is absolutely essential that we start on the very beginning, on day one, first time in, and every time we step forward a little bit, every time we remove a symptom or we remove use or remove a drug, we want to adjust that return to use plan to compensate for that and help that client identify what are they going to do if they have one or two small steps backwards and where are they going to move from there. Now, when you're looking at the stages of change, and if you haven't watched that video, you can click back over and look on that one. It'll really help you in treatment planning. When you're looking at the stages of change, a lot of models will label relapse as a stage of change. I don't do that. I use return to use to return to symptoms, and I don't really consider it a stage. You'll see on my model, I have it in the middle. It's essentially a road that moves you between one stage or another. And so, for example, if you were in the maintenance stage of change and you had no symptoms for a period of time, and then you take one step backwards, that's going to go through the return to use road, and then it's going to take you back into one of the other stages. So are you going to go back into action? Are you going to go back into preparation? Are you going to go back into contemplation? Presumably, you can't really get back to pre-contemplation because you've already acknowledged there's a problem. So you're going to kind of look to see when they return to use, looking at it in the center, which road is that taking them through? How far back is the client going to go? And ideally, we want to just take them that one tiny step back into the action stage or change where we can get them right back on track, help them identify the skills necessary, what mistakes will happen, how we need to add a plan to it, and get them back over into that maintenance stage of change. Meanwhile, it is really important to go back to that model that I mentioned earlier. This is where AA and NA get it 100% right. It's easier to do something if you're helping someone else do something. So when your client takes one step backwards, don't throw all of that hard work away and put them back at the beginning. Encourage them to go into group counseling. Connect them with other people to talk to and to mentor. Let them show their transparency to other people, because even when they're in a step of returning to use or coming out of a step of returning to use, that can be so helpful to someone else who is experiencing ongoing or trying to get from that preparation into that action stage. And so if you have someone who is in maintenance and they took one step back into action, encourage them to continue helping those people who are in contemplation and preparation. They are still so far ahead of them, and they can still come in and help them. And as they come in and help them, it's going to help themselves as well. And so that connection between people and bringing it in. The more that we reduce shame for our clients, the more likely that they are to have real positive, long-lasting change. Again, just to reiterate, shame is one of the largest driving forces behind ongoing drug use or ongoing negative symptoms. Essentially, drug use and alcohol use, most negative mental health symptoms like anger, worry, those are avoidance tactics. And so they're avoiding uncomfortable feelings. Shame is a very uncomfortable feeling. So if you shame someone who is addicted to drugs, they are going to do whatever is necessary to remove that uncomfortable feeling. And that will likely, unfortunately, be to use more drugs or to use more of whatever they happen to be addicted to. And so when you're working with your clients on reducing the shame and moving them forward, it's essential that they learn not to shame themselves, and that you as a clinician learn how to prepare them for steps backwards, and that you learn how to prepare them to improve that self and to look at that view of self and stand up in the shame and not be held back by that fear of letting other people know what's going on in their life. The faster that you admit that you have returned to youth, the faster that you can get better.